So today's session, session 6, is focused on incorporating community health workers and peer support specialists into your workforce. We're going to talk through 2 new Medi-Cal benefits, and we'll also talk about ways and strategies that your team might better support people with lived experience, and then how this relates to some of our upcoming Medi-Cal Academy trainings on policies and procedures, documentation standards, electronic health records, because all of these things also tie into how we can best support staff with lived experience. For those of you that have not joined previous sessions, we are funded by the California Healthcare Foundation to put on this Medi-Cal Academy training series. And my name is Cheryl Winter. I work at CSH, Corporation for Supportive Housing, and we are a national nonprofit. We work in all 50 states. We focus on innovative solutions that support housing as the foundation for people's healing and recovery and stability. Today, I'm going to be joined by Carmen Miller. Carmen is a community health worker and a peer specialist with the Los Angeles Department of Mental Health. She's going to be joining us a little bit after the start of the hour. So when Carmen joins, probably toward the second half of our time together, then we'll make sure to give her a chance to introduce herself. Okay. So today I want to focus on 4 elements related to incorporating people with lived experience in the workforce. Firstly, just introducing these 2 new Medi-Cal benefits that support hiring and the reimbursement of services that are specifically focused on services provided by people with lived experience. Both of these new benefits call out lived experience of homelessness, and so I wanted to point these 2 out to your agencies today, as I know many of you in your applications to the Academy said that you either hire staff with lived experience or you include people with lived experience in leadership decision making. I want to then go into the agency requirements. So what it takes to be a provider of these services. What are the individual requirements for the peer specialist and the community health worker? What are the eligibility requirements for the people served? And then what are the agency requirements in terms of any certifications or contracts held with the Department of Healthcare Services? We'll then go into best practices for supporting our workforce and ways to intentionally create safe and inclusive work environments to support peers. And then lastly, we'll go into some of the resources that you can dig into after today's session that there is a lot still being developed and coming out related to the community health worker benefit and the peer support specialist benefit. And there are some key partners that we'd want to encourage you to be reaching out to, giving feedback to, asking questions to, so we will provide that information. Okay, we've already started to talk about what we're going over. I want to now just say some of my hopes for you and in terms of takeaways is that you'd come away with some practical tips around supporting and retaining people with lived experience. We will be joined by Carmen Miller, who will be sharing more about her experience. I want to highlight that there are other ways that your agency can be engaged with Medi-Cal beyond CalAIM. And it was nearly half of the agencies that were a part of this Medi-Cal Academy whose core are in homeless services, but who may be billing Medi-Cal for other items as well. And so some of you may be poised to immediately start providing these services. Others may need to pursue certain partnerships with other federally qualified health centers or healthcare providers so that you can get referrals for these services. So my hope is that you'll be able to identify next steps if you want to pursue being reimbursed by Medi-Cal for services provided by people with lived experience. And then lastly, that you have access all in one place to the resources. There are many on the Department of healthcare services website, lots of others on different nonprofit and health association websites. And so we've tried to put those all together in one place today. Before we jump in, I'm hoping that I can hear from all of you just what is important to you in terms of why we should hire people with lived experience and include them as both staff and leaders. And I know that some of you bring lived experience to your work as well, and so would love to get us started in that mindset before we dig into the two benefits that we're going to focus on today. All right, so I think I already gave a little bit of background about why we're shifting from community supports today to talking about other Medi-Cal services and benefits, so I won't go into that. But we know that people with lived experience can bring empathy, connection, hope, and the belief that recovery is possible is woven into all that they do because they are living that proof. And so it is often that organizations and nonprofit organizations have staff who are on staff with lived experience who may not have disclosed that lived experience. And so part of calling out specific provider types as being peer support specialists or community health workers is identifying that when people are willing to share their experience with others and identify that they too have lived that can be powerful in giving and lending hope to others who are going through similar circumstances. These services have been eligible for Medi-Cal reimbursement through multiple avenues already, through targeted case management and some other codes. But what I'm going to be talking about today are two benefits that explicitly have new provider types that are calling out that the provider has lived experience and has gone through a certificate program or has work experience as a peer that then grandparented them into this new provider type where they can be reimbursed for specific services related to recovery, health education, and advocacy. We had an earlier session on evidence-based practices in practice, and in a poll that we did with Medi-Cal Academy attendees, we asked about if teams were able to have smaller caseloads. Were you able to provide 24/7 round-the-clock support, be it via phone or telehealth? Were you able to bring in staff with lived experience, and were you operating in a multidisciplinary team environment? What we're seeing with these new benefits is that it's giving opportunities to move closer to that multidisciplinary team-based care model. And there is still some creativity that's required for providers in terms of braiding in funding and braiding in partnerships to have those true multidisciplinary teams. But by bringing in peers that have their own unique billing codes and rates, it does get us closer to potentially having smaller caseloads if you're sharing caseloads between a housing case manager and a peer support specialist. And also some peers are able to bring with them flexible hours, and it may provide for some additional coverage in that 24/7 support. So there are ways that we can think about how we want to incorporate peers into the workforce that can get us closer to this evidence-based practice model of multidisciplinary team-based care. In past sessions, we've also highlighted that it is important that people are served by people who look like them and who have similar experiences, because we know that when that doesn't happen, people can experience racism and bias and discrimination in services. We saw that in Los Angeles in a recent study that was published where Black clients were 38% more likely to return to homelessness. And one of the reasons that was cited in focus groups and from the study was that Black tenants were more likely to receive inadequate case management and also were confronted with anti-Black racism. So this is just one more reason why we want to encourage the inclusion of people with lived experience, who have those lived experiences and come from the communities that you serve. The other piece, which this is another report that we focused on in a previous session, um, is around the intersecting needs of housing and recovery services. So if you are already providing homeless services and are not yet a mental health provider or substance use treatment provider, um, there is so much intersection as now homeless services and housing tenancy support services are entering into the healthcare space. These intersections, um, they already have been a reality, but they're going to be more of a reality in terms of how you are funded for your services and who your partners need to be in terms of coordinating around plans of care and the provision of services. And so there are opportunities also to think creatively about how peers and the peer workforce can be either shared staff or supervised by one agency, but partnering with a housing supports team. So there are some creative ways that we can think about bringing in staff with lived experiences to help meet those intersecting needs of housing and recovery services. I wanted to also highlight when we talked about evidence-based practices, we highlighted two that were team-based approaches. And then I want to share this slide and then another slide that is looking at how things are right now in California in terms of CalAIM, community supports, and then the integration of these two additional benefits. So on the left side of the screen, you can see this is the assertive community treatment team model, where it's a team-based approach. The entire team works under the same agency, has the same supervisor, and is coordinating care on a daily basis. The same exact caseload of people that they're working with. And so care coordination happens in terms of best practice fidelity to the model. It's required to happen daily, but it also is easier because it happens with a team that all is working at the same agency using the same database systems, and they are coordinating care amongst their teammates. On the right-hand side, this is a model where you may have a housing case manager or an intensive clinical case manager who is working directly with a tenant, but then coordinating care with other specialists and holding that care coordination role in addition to providing housing services. This care coordination role has often been informal in homeless services, where homeless service providers have been doing a lot of care coordination, but not necessarily being funded to do it. And so now we are seeing that, enhanced care management and community supports are being funded, and enhanced care management entities may or may not be the homeless service provider agencies that are connected on a day-to-day basis with people who are unhoused. So you'll see there are far fewer lines in this model. This is, I'm trying to show that we are at the beginning stages of figuring out how care coordinators in enhanced care management can then identify and work with housing case managers, how a peer specialist or a community health worker might advocate with a tenant to select an enhanced care management provider that they already know, that they have a relationship with, that is in their county, that they feel most comfortable with. There are roles where people with lived experience can help support this coordination and all of these new activities that are happening with CalAIM and community supports that is still outside of CalAIM and community supports, but would fit under the category of advocacy or healthcare navigation. All right, so let's dig into the two benefits. I am going to present a little bit about each of the benefits, and then I have a few slides where I'll be comparing the two side by side. There is a good amount of text on some of these slides, and so I just want to say that all of these slides I have included in a PDF. I will send them to you after this session, and all of the links are active. So once you receive the PDF, you should be able to click on any of the supporting documentation and resources that we go through today. Okay, so the Certified Peer Support Specialist position. Um, Curious if any of you want to show through raising your hand or putting in the chat if you are already billing for the Certified Peer Support Specialists within your county. This is a new provider type within specialty mental health services programs and drug Medi-Cal organized delivery system programs. So in the past, peers could have been providing services through specialty mental health services or drug Medi-Cal services, but they were billing under a different provider type, maybe under targeted case management or something else. This is now a new benefit that has its own rates and its own provider type. With that, there are specific areas of specialization and new certification training programs available to peers. And so this is an area where you may have folks on staff who are identified as peers who have been being reimbursed through a certain provider type and billing codes, but who now have opportunities for additional training. And there is opportunity for career advancement into supervisory roles as well, with supervisory trainings available through this certified peer support specialist role. You'll see number 3 in terms of areas of specialization. One of those areas of curriculum that's being developed for certified peer support specialists is on serving people who are unhoused and who are experiencing homelessness. Right now, that first area of specialization has been developed, and the other 3 are in process of development. Not all California counties opted in initially to provide these services. There was a deadline of May 2022 for counties to opt in, and then every 6 months counties will get another opportunity to opt in. So on this map, you can see that most counties said yes, they want to have peer support specialist services in their county in both their SMHS, their mental health services programs, and in their drug Medi-Cal or drug Medi-Cal state plan programs. There are a few, those lighter blue counties, where they opted that peer support services as a provider type would only be available through their specialty mental health services program. And then there's one county that opted just that it would be available through their drug mental health or drug Medi-Cal delivery system. There are 8 counties that hadn't yet opted in, but they again will have the option to opt in every 6 months. And so if this is a county that you're working in, this could be an advocacy area for you if you wish to pursue being reimbursed and hiring peer support specialists. Counties are determining both the certification program and process for peer support specialists in their counties. Many have chosen to then go with a vendor to develop that certification so that it's a common certification standards and processes across the state. But you can find details about each county's peer support specialist certification program. This one comes from Placer County, and so they are offering some clarification around the difference between a certified peer and a non-certified peer. Given that peer services were already a part of their mental health services delivery system. All right, I'm going to shift now to the second opportunity for including people with lived experience, and that is community health workers. So community health workers are focused on health education, healthcare navigation, preventive health services to address and provide services to people who have one or more chronic health conditions. The agencies providing community health worker services could include licensed provider agencies like a community mental health center, like a federally qualified health center or primary care provider. It could also include local health jurisdictions or community-based organizations like yourselves. So while the first option of certified peer support specialists is really only available for those of you that are contracted with your county mental health systems or your county drug Medi-Cal programs, community health workers, this service is available and can be supervised by providers who are community-based organizations. I put an asterisk here because in order for a Medi-Cal member to receive community health worker services, it does need to be um, they need to receive a referral from a recommending provider. That recommending provider does need to be a licensed provider. So that would mean a primary care provider, a street medicine provider, a nurse. There's a list of recommending providers, and it needs to be community health worker services need to be included in that person's plan of care. So this again is where you as a community-based organization may hire community health workers, and those community health workers can work with Medi-Cal members that you are serving in housing programs if included in that person's plan of care by a medical provider. It says that they would benefit from having support from a community health worker. All right, so on the left side of the screen from here on out is the comparison between the two, and I will try to highlight the differences and some of the similarities. For peer support services, the focus is on promoting recovery, promoting engagement. A lot of the literature talks about that peer support specialists not only the outcomes show an increased dedication or increased levels of hope and resilience in people who receive peer support services, but also increased levels of engagement and increased levels of client satisfaction of services. So the peer support specialists are focusing on helping someone to identify their strengths, helping them to identify areas where they may have goals, but maybe actions and behaviors don't align with those goals, and how they can support them in developing natural supports, being engaged in the community, maybe accessing other community resources. And there's a big emphasis on socialization. So there could be educational groups provided, therapeutic activities, and time just for engagement. So getting to know one another and building rapport. On the community health worker side, those tend to focus more on healthcare navigation, on prevention. It can include violence prevention, but on anything that can help to prolong someone's life and promote physical and mental health. That can include screening and assessment. It can include health navigation. And so we've talked a bit about, the role of community supports providers in connecting and coordinating with enhanced care management and primary care. A community health worker can support in navigating those healthcare systems and can be an advocate for your tenants in helping them to select the enhanced care management provider that they want to work with. It can help them to find their voice in saying, this is the plan of care that I want. This is who I want to be working with as we coordinate across multiple care systems. Both include individual support and advocacy. However, the peer support specialist has more of an emphasis on supporting self-advocacy, so helping to model to an individual how they can advocate for themselves. And then the community health worker can advocate on behalf of the patient. In terms of eligibility for services, so because peer support services are a provider type within the mental health service system and the drug Medi-Cal programs, They are available for anyone who is already eligible for services in that program, as long as peer support specialist services are included in their treatment goals and their individual plan of care. What I'll add though is if someone is eligible to receive services through mental health programs or drug Medi-Cal programs, and they aren't interested in participating in any therapy services, any inpatient services, they don't want to go to groups, they can still receive peer support services. So they don't have to be actively engaged in that programming. It's just that they need to meet the eligibility criteria for those programs in order to receive the peer support services from certified peers. For CHW services, I'll give you a minute to read through these. And I just want to note that I've highlighted or I've emboldened some of the phrases that are similar to what you see in the eligibility criteria for housing related community supports. Many include the diagnosis of one or more chronic health conditions. This could, be a behavioral health chronic condition. There needs to be the presence of one or more of these bullet points. So even if someone has nothing other than, let's see, it's the fifth bullet point down that says the results of social drivers of health screening indicating unmet health-related social needs, such as housing or food insecurity. Even if someone has just that one need assessed, and so they may have been deemed eligible for housing related community supports, they could also be eligible for community health worker services. If a provider that you are partnering with or that is a licensed provider on your team recommends that this person receive community health worker services. So this is a long list, but they only need to have one of the following on this list. You'll also see that it talks about the number of hospital emergency department visits. It talks about if medical appointments were missed, and the requirement for that is that there are 2 or more missed medical appointments within the previous 6 months. We know that many times when someone is unhoused, tracking medical appointments and attending medical appointments is very difficult. And so some of these threshold criteria for working with a community health worker, you may be working with tenants or folks who are unhoused that meet multiple necessary. And so it's really then about how are you bridging relationships with a rendering provider who would recommend that someone receive community health worker services. There are different qualifications for both peer support specialists and community health workers in terms of the worker, what's required of the worker. For peer support specialists, they need to be at least 18 years old and they must have a high school diploma or a GED. This was something that came up in focus groups that CSH did with existing peer workers as a challenge or a barrier potentially for individuals who did not have a high school diploma or didn't have an equivalent degree. The community health worker expectations or qualifications does not include that. So this is one difference between the peer support specialist role and the community health worker role, that depending on who you have on staff already, it may be worth pursuing one avenue or the other. Both need to identify as having lived experience. Both include possible experience that is lived experience of homelessness. However, for the peer support specialist program, or provider type, because it sits within the mental health services and drug Medi-Cal programs, they also need to self-identify as having an experience and being in recovery from a mental illness or substance use disorder, or they could be a parent, caregiver, or family member of someone who has been a consumer of those services. So again, they need to then tie directly to mental health services or substance use disorder recovery services. For peer support specialists, it explicitly states that they need to be willing to share their experience that is not listed as the minimum requirements or qualifications for community health workers. Although it is something that is, talked about in multiple areas of the qualifications that they must have that lived experience. And then there are training requirements for the peer support specialist and the community health worker positions. They are different in terms of the number of hours and in terms of the cost. So I have included links to the two different um, sections. I would say that the certificate pathway on the community health worker includes both training and demonstration of proficiency in certain training areas. There's also a work experience pathway where if someone has had a certain number of hours past work experience, they could also meet the minimum qualifications through that. And then there is an annual training for community health workers that's required, that is a minimum of 6 hours. In both cases, programs that hire peer support specialists and community health workers can add on additional trainings and offer additional supports. The costs for the peer specialist certification is determined by the county, and counties have to submit that each year to the state. And I've seen a range of costs. In Los Angeles, those costs can be several $100s. And so we are looking at ways that programs could fund or cover the costs of the certification training program and the exam for staff. So these are just some things to consider as you're looking into both options. And again, it really depends on if you're a community-based organization that's not billing Medi-Cal for anything else, or if you already are providing some mental health services or drug Medi-Cal services. Okay, in terms of supervisor requirements, each come with their own requirements around who can supervise and who can submit the claims. For the peer support specialist role, there are specific trainings that a supervisor will be required to take. Again, these are trainings that are developed by the county. Sometimes that's subcontracted out to another entity to develop those trainings. But someone who has previously been a peer and is a certified peer can be a supervisor. So you don't have to be licensed as a licensed clinical social worker or another license provider type to be a supervisor for either of these roles. In the community health worker role, the supervising provider can be different than the recommending provider. So remember I said, if you're a community-based organization and you don't have a doctor or a nurse or someone that is licensed to say, we recommend this person work with a community health worker, that person doesn't need to be on staff. They are the recommending provider for the services. Who is on staff would be the supervising provider, and that person does not need to have a license to provide the service. So it can be someone who's from a community-based organization. The rendering provider will need to make sure that whatever was written in someone's medical plan of care, their individualized plan of care, that those services are being met by the community health worker. So it requires some type of formal arrangement or coordination between you as the community-based organization and whoever that referring provider is. And then in terms of billing, so we talked a little bit about different reimbursement structures in an earlier Medi-Cal Academy session. Each of these opportunities have different units of service in terms of the length of time for a unit of service, but both use the fee-for-service billing method. What that means is when someone is providing their peer support specialist services, they are going to be providing those in 15-minute increments. So if I sit with someone for 34 minutes and we're working on something together, we're talking through a recovery goal, or we're um, working on something related to self-advocacy. If it's 34 minutes, that would mean it's 2 units, because 2 units of 15 is 30 minutes, and it's not yet to 3 units. So I would write out a progress note that is documenting my start time, my end time, and the number of units. When we talk in future sessions about documentation and electronic health records, there are systems that can do this automatically for you. But this fee-for-service billing is pretty typical with providers that are already doing mental health services and drug Medi-Cal. I've included the codes that have been offered up that for billing and for claim submission. So self-help peer services, H0038, or behavioral health prevention education services, and that's for any group activities. That's H0025. There are links at the bottom of that column that can give you more information if you are already a mental health services provider or a drug Medi-Cal provider and looking to bill for peer support specialists. And again, we'd love to meet with you for one-on-one TA and support you in that if this is an avenue that you're looking to pursue. For community health workers, the unit rate is set by the Department of Healthcare Services. So it's not overseen by a county system. It is by the Department of Healthcare Services at the state. And their definition of a unit for community health workers is 30 minutes. They have set that there is a maximum of up to 2 hours a day per person served. But if you anticipate working with someone for more than 2 hours, there are ways that you can include and request to work with someone for more time. But in general, when you think about community health workers working with individuals, it's for a maximum of 2 hours per person that they would work with them. Again, this could be accompanying them to appointments. This could be helping them to navigate the different services they are enrolled in, the different benefits that they're eligible for, or it could be around advocacy. I am thrilled that you're here with us, Carmen. Thank you.
Thank you for having me.
Yes, it's so great. So for all of you that are in the Medi-Cal Academy, Carmen and I got to work together over a year ago, doing some focus groups with people with lived experience who were working as peers. And Carmen had a key role. She was on the cover of this report called Advancing Health Equity Through Skilled Peer Workers. So Carmen, I want to give you a chance to introduce yourself, and then we'll just have a little conversation about ways that organizations that are thinking about hiring peers or maybe wanting to pursue Medi-Cal in paying for peer workers, what your recommendations would be for them. But I'll let you introduce yourself first.
Hi, everyone. My name is Carmen Miller. I am a community health worker for DMH. I have worked for them for like 3 years. I'm sorry, 3 years now. Before that, I was a wellness outreach worker for DMH down at Mental Health Headquarters, the Peer Center. And so, yeah, that's a little about me. And so what questions do you have, Cheryl?
Yeah, I think first of all, I just would love to hear from you. If you were talking to providers that haven't hired people with lived experience yet, what are some of the things that you'd want to recommend they have in place in terms of help with supervising, or really any general recommendations?
One thing I would recommend is having a to-go-to person, for the peer to connect with, and like any problems throughout the day when they first start working there that they're unsure about. And because sometimes you may say, oh, do you understand? Ask everyone as a group. And then of course, everyone is saying like, oh, yeah, I understand. And then there are several people, or maybe all the people, everyone, they won't understand. And so I would like for just show an example of whatever the subject is, whatever the task is, to just tell everyone how to do it in a whole instead of just asking everyone and singling someone out. They're like, oh no, oh yeah, I got it. And they really don't. And they go back over to their desk and they're struggling.
Mm.
So things like that, yeah. And as far as IBIS is concerned, like when I
And
learned,
IBIS is your documentation
mhm,
system.
mhm.
Okay.
Yeah, I was taught IBIS by video. So I had to watch a video and give me instructions on how to work in IBIS. So that didn't work for me because I don't learn like that. And so a bunch of people, they just were like, you just get kind of it kind of makes you anxious and
Mhm.
kind of makes you just feel like, oh gosh, other people have it, I don't. But I learned by going on Teams and getting instructions like that and
Mhm.
sharing my screen and being taught how to share my screen. And then I went from there because there was a time when I was teaching a group and having clients, and I was all backed up in IBIS because I didn't know how the first thing about IBIS. And so there are things like that that you can help out with a peer. There's a way
Mhm.
you can help with a peer like that.
One of the agencies I worked for in the past, we had hired a number of peers, and they each had their own supervisor, but then I served as, like you said, like a coaching role that was
Uh-huh.
not related to their performance evaluation. So they didn't
Mhm.
have to worry that I wasn't their supervisor, but
Right.
it was a support role of any
Yeah.
questions they had, especially for documentation. Do you think that type of mentorship, where it's not connected to the supervisor, is that what you're talking about?
That's excellent right there. That's excellent because we were talking about on another meeting that I was on about mental health days. Because sometimes, you have a day where, hey, I'm just not feeling too well. And for the supervisor to be able to understand that and yeah, you need extra support sometimes.
Mhm.
And yeah, where I am right now, my I was a client there. And so my therapist is now my supervisor. And I know how you all probably are like, how does that work? Well, it took some time to getting used to, because the
Mhm.
roles switch, they switch. Now I'm looking at this person as like, hey, this is the person who is teaching me, but she did teach me in a different kind of way before. But yeah, it works. It can work if you want it to work. So
Mhm. And it
yeah.
sounds like you have to then figure out boundaries and
Hmm. Hmm.
probably find a different source of support if it's
Exactly.
that type of smaller agency.
Exactly. And some of the clients, they were also my friends. And so I had a different role right there also. But it works as long as you know your boundaries and it can work. Yeah, it can work.
Some of the things, so we had this listening session. I mean, again, now it feels recent, but it was over a year ago. And so I'm going to put on the screen some of the things that came out of that.
Mm-hmm.
People were giving recommendations around, establishing workplace wellness, not only programs or
Mm-hmm.
like changing the structure of how people can ask for paid time off so that mental health days
Mm-hmm.
don't hold a stigma, but
Right.
also like writing it into policy, like how do we check on each other and how do
Yeah.
we ensure that do you have any um,
Now,
recommendations or comments about those?
now that we are speaking about mental health days, like that's like kind of blurry because like we were asking, what is a mental health day? Do you use your own personal time or does the company have some time that they offer to you? So I've never received the answer to that. So
Hmm.
I don't know the answer to that, but I know so far we have been receiving higher wages and better benefits since
Hmm.
this. And yeah, and building internal support and infrastructure. Yeah, I'll say it's getting better. It's getting better. Mhm.
And I'll say for the higher wages and better benefits, so this um, peer specialist, certified peer specialist, peer support specialist
Uh-huh,
provider type, there's a rate that the county sets that then reimburses an agency for every 15 minutes of work.
uh-huh,
And I've seen the rates, they range between like $18 for 15 minutes all the way up to some of them are around $50 for 15
mm-hmm,
minutes.
mm-hmm.
So if a provider decides to go that route, they then would have the ability to pay a better hourly rate than maybe what they're paying if they're just getting grant funding.
Right, right.
Can you say about, the internal support structure, what types of things would you recommend an agency have in place in terms of if they're hiring a
Well, as far as the
supervisor,
support, say it one more time, Cheryl. I didn't
in
catch
terms
that.
of supervising or supports?
Yeah, I would advise a little bit more one-on-one, a little bit more one-on-one, so the peer can feel like I'm not a peer anymore. Like I
Mm-hmm.
am a community health worker and I am a professional as just like a therapist, occupational therapist, the medical caseworker, because you will feel a little bit of the little you and big me, to get away from that right there. So yeah, and just for people to be treated equally. And
Mm-hmm.
so yeah.
Yeah, that's something that came up, I think, the last time we talked too, of just if there's not role clarity around the expertise that you bring and what you should work on,
Mm-hmm.
that sometimes the negative side of it is if there's not role clarity, sometimes peers are put into roles that are um, demeaning or, like
Right,
here, set
right,
up
right, right,
chairs for
right.
this
Yeah,
staff
because when
meeting
I
or
first
make
started
copy.
working, when I first started working for DMH, yeah, we would have to do things that didn't have anything to do with our job title. We were setting up like for people to eat and everyone else is just sitting there watching us work. And that was like really the feeling, it was like really belittling.
Hmm.
Yeah, we did. It was very belittling. And just to go out during COVID, we were the ones that had to go out and visit the clients when COVID first hit, when at the really crucial time. And so, yeah, we did. Yeah. And I feel like if we did it, everyone should have had to do it,
Hmm.
so.
Yeah, so that's a really important consideration for agencies
Mhm,
that haven't yet hired
mhm.
peers. I think
Yeah,
especially don't hire just one person because you don't want someone to feel like they are a token or like
yeah,
having to
yeah.
represent
Or if
everyone.
you have two, everything you do, you put those two together. You two do it, you two do it, you two do it. When I'm like, okay, I'm one individual person. I'm
Hmm.
able to do it by myself.
Hmm.
Yeah.
Yeah,
Mm-hmm.
and then a lot of thought around how do you create a workplace culture that doesn't treat people with a license or a different title
Mm-hmm.
better or
And
differently than
and
someone with lived
and
experience.
are you have the therapists that treat the community health worker like he or she, they're the supervisor, and they're not. And so yeah, yeah, things like that.
Yeah. So there's like really exciting opportunity with these new positions being reimbursed by Medi-Cal, but I think for agencies,
I've
we have to
already
be really
been,
thoughtful about it.
yeah, I've been doing that for like a long time without being a peer specialist. I'm not a peer specialist right now. I don't have my license, but I've been billing Medi-Cal for a long time.
Mhm.
Yeah.
Can you say a little bit more about for the documentation pieces? Um, we have a training coming up in a few weeks that is going
Uh-huh.
to be for all of the providers on this call about what's new for writing a progress note for Medi-Cal.
Mm-hmm.
Because it's really different in terms of how you word things and how
Uh-huh.
you write things.
Uh-huh.
Um,
Yeah,
but
yeah. So yeah, for me, I learned if someone was going to teach me the way how I learn, I would like to learn it over teams and everyone has a chance to see, what everyone else is doing. Hey, I didn't catch that. So, and then also, if there's a training, in-person training, then, oh no, not in person, I'm sorry, on Teams to record it. So you can go back and say, hey, oh, I missed that part right there. And then you can easily work through that. So I would like to see it on Teams and record it. And so I can go back, not just someone saying, giving a IBIS training, and then you go back and say, hey, and then she's going through the training. Oh, next, you guys all know this. So giving a refresher course, that's what I meant to say, a refresher course. And so you're like, oh, wow, I don't know that part. But you don't want to stop the whole training and say, hey, I didn't get that, because they're guessing that you already know that. But like me, myself, I don't like to stop the training and say, hey, I didn't get that. And so therefore, then I don't know it. I have to go to my supervisor and as if I'm lacking or I wasn't paying attention, but I am paying attention, but I'm not familiar with that.
Mhm. Thanks. Yeah, and I think honestly, there's so much in what we can do to better support peers and people with lived experience that
Mhm,
actually strengthens the entire agency.
mhm.
Um, there was a comparison once that was given of, when you make an accommodation or a change on behalf of one group of people, how it benefits the whole community. And the example was like for sidewalks, how when you have to make that cutout or the divot at a corner on a sidewalk
Oh,
for
yeah, yeah,
someone
yeah.
with a
Mhm,
wheelchair to go
mhm,
down, up and down,
uh-huh.
that
Yeah,
also helps, someone who's pushing a baby stroller. It also
right.
helps someone who is carrying a suitcase. It
Yeah,
also helps someone who's delivering a big package. Like it
yeah.
benefits everyone. And I think when we think about supporting peers, when you're talking about a mental health day, we all
Need
have
a
days
mental
where we
health day.
need mental health days.
Yeah,
And so how
yeah.
can we think about like our policies and our procedures?
How can we say that without feeling embarrassed or ashamed to say like,
Hmm.
today I'm suffering with mental
Hmm.
health and I need this day off or a couple of days off
Yeah.
without like, you may have a group that day.
Hmm.
And so you're like, dang, I have to then you feel guilty because the group is not going to take place. And then you're feeling embarrassed because you have to tell your supervisor, hey, I need a mental health day.
Yeah. So thinking about coverage in terms of knowing that if peers are coming with lived experience and are in recovery,
Uh-huh.
that it makes complete sense that there will be days where you need to focus on your own recovery.
Right.
And that policy or process will benefit all of staff, knowing
Mm-hmm.
that we all are going to have
It
days that
definitely
we need
will
coverage.
benefit. Yeah, it definitely will.
I want to open it up to those on the call and just see if people have any questions for you, Carmen. And if there's anything else you'd want to share with the group before we shift gears. I'm so thankful that you're all
Does
here.
anyone have any questions? Okay.
It's been a quiet group today.
Right.
Well, I want to encourage everyone to read the full report that's called Advancing Health Equity. There are a lot of pieces in there that focus on how to support peers and people with lived experience in the workplace. It also highlights a training program that CSH worked on. And Carmen, you were a part of that first cohort called HEAL.
Right. All right.
And talks about some of the strategies for supporting peers and making sure that a peer role is not just that there is room for advancement. We want to make
Mhm.
sure that you could work in any position at an agency. You could be the executive director, and that, training and supports can help you to advance and grow in your career. So this report talks about that.
Mhm.
And Stacy is saying, thank you for sharing, Carmen.
You're welcome.
Right. So in our last little bit of time together, I'm going to shift gears. But Carmen, feel free if you see any comments coming in the chat, or if you have any other ideas, feel free to unmute yourself and pop in and share with me. I'm just going to be sharing some additional resources now.
Okay, will do.
Awesome. Thanks. Okay, so this report, some of the things that it talks about is, we see that Medi-Cal and Medicaid programs often focus on what are the health outcomes of bringing in people with lived experience. So it highlights that um, agencies can benefit and peer workers can benefit from Medi-Cal reimbursement because it directly can impact higher wages. It can impact how you provide benefits and what benefits are provided. So as Carmen was talking about those mental health days or personal days, one of the agencies that I worked for in the past, we had to change how our HR system structured paid time off because as we hired more people with lived experience, people had their own therapy appointments and doctor's appointments that happened in the middle of the day. And they wanted to take maybe 1 or 2 hours of PTO at a time, pay time off at a time. And at the time, our structure or system was you take an entire day off if you're requesting paid time off. So we had to work with HR, we had to change our policies and some of our processes. Um, to work on that as we changed our benefit system of how we tracked paid time off. And then we also had to work on getting some short-term disability insurance. So wanting to be able to provide short-term disability and making sure that it was affordable so that if people did go through a crisis and need to focus on their own recovery, that they didn't have to worry that their job wasn't going to be there. So they were able to take that short-term disability, and we were able to get it for everyone in the agency. So it was only $1 or so per paycheck that was taken out for that short-term disability, but it did mean that we were able to retain staff even if they experienced a crisis. So I just want to encourage you as you're thinking about hiring peers, think about how your agency can support them, what you need in place, and how that'll benefit everyone so that you're not seeing people with lived experience as a unique group that you're catering toward, but really as a part of your whole workforce that's going to make you a better agency. And so this is a little bit more, we're just going to dig into some of the key partners. So for these two Medi-Cal benefits, there are some links here that I want to encourage you to follow up on. But if you have questions about the peer support specialist certification program and how it's rolling out in different counties, there are representatives that can support you and take your questions. These are council members that are a part of this advisory council that are set up to receive feedback and questions. So in this provide feedback column on the far right, those are links. So when I send out these slides, you'll be able to link to the individual that is set as your advisory council member to receive feedback, because they are constantly building out and providing more guidance on how this is being rolled out. This is a new benefit. It's a new provider type. It's new as of July 2022. So they are still learning and tailoring things. Things are still being put online. So we want to make sure that you have someone you can go to reach out to. There's also a general email address, peercertification@calimsa.org, that you can also reach out to. As we're talking about building health partnerships, in the past, we've talked a lot about community supports and housing related community supports and the partnerships that are important to align services with housing. We've touched a little bit on enhanced care management, but I want to highlight a few other provider types that we've talked about today, or who might be critical in helping you to connect the people that you are serving who are unhoused or who are living in your permanent supportive housing or rapid rehousing or shelters to community health workers. So recently, the Department of Healthcare Services has said that managed care plans can now pay for street medicine providers. They can pay for street medicine teams who work in the community doing street outreach, providing medical care to people who are unhoused. This is a brand new thing that managed care plans can pay for. It's very new and being rolled out. And in Los Angeles alone, we've seen that there are now 4 times as many street medicine providers in recent months as there were before the this announcement from the Department of Healthcare Services. So this is very new. But one of the exciting things about this is that street medicine providers, doctors who are going out in the community doing street outreach, working with people who are unhoused, they can now be considered someone's primary care provider, where in the past they couldn't. With that, they can be referring people for services. They can refer someone for community supports. They can refer someone for community health worker. They can write in a person's plan of care that they have a community health worker that they work with. So if there are any street medicine teams starting or already happening in your communities, those are going to be teams that you'll want to connect with, especially if you're thinking about hiring community health workers. Federally qualified health centers. A lot of these federally qualified health centers are the nonprofit healthcare providers that offer primary care, and many of them are the ones that signed up to be enhanced care management providers. So these are groups that you may or may not already be connected to, but who will be, again, really critical partners in referring people for community health workers. So community health workers can help to connect folks to you, or they could work for you and connect people to primary care. So it's kind of a dual role in terms of healthcare navigation and education and advocacy. And then again, community mental health clinics and the drug Medi-Cal treatment providers, they can hire peer support specialists. Many of them already have peers on staff and use a number of different terms for those peers. Like in Los Angeles County, the Department of Mental Health has called peers community health workers, and they've billed under targeted case management, whereas now there is an entire new provider type. So these are just some of the partners that if you're not having conversations with them right now, I'd recommend that you start having some of those informal conversations. If you want support in that, we have a number of tools that can help you think through who you can reach out to in your community and how you might partner with them. Because there are lots of ways to partner informally or formally to help in referrals, access to care, access to enhanced care management, access to peer specialists or community health workers. Okay. Now, in terms of resources, since this was a lot of information today, there are lots of sites that explain the peer support specialist certification program. Cal Mental Health Services Authority, Cal IMSA, is selected by many counties across the state to be the ones developing the certification program, the training, and the exams. Some counties are doing it on their own, but many have decided to go with Cal IMSA. There's also an FAQ document that is very long that the Department of Healthcare Services has on their webpage that explains everything from like who can be a supervisor, how do we bill, how do we understand the rates. What's unique about the peer support services reimbursement rate is that it's set by each county. So it'll be important for you to connect with your county Department of Mental Health to understand what rates are set for your county. But again, these are probably rates that will be better than what you are currently receiving from grants. But as Carmen said, the documentation, that is a learning curve. How you say, what you did every 15 minutes to justify your time is going to take some time. So we will focus on that in a future session so that you can make sure that you are getting reimbursed for all the time your staff are spending with people. For community health workers, there is a lot of information about the benefits of having community health workers, all of the different resources, and how it's rolling out on the California Healthcare Foundation website. So that very last line there, community health workers and promotoras in the future of Medi-Cal, that is a entire learning page built out by the California Healthcare Foundation. On the Department of Healthcare Services website, there is also information on the community health worker benefit, as well as a fact sheet that we've linked a number of times through this presentation. So we'll highlight these resources, but I encourage you to ask any questions because, again, these things are new. I'm just seeing some of the administrative responsibilities being altered slightly in terms of when counties have to opt in or how they post their rates online. Some things weren't required that are now being required in terms of that transparency. So this is still rolling out. So no question is a dumb question, but I just want to offer these two as options as you're thinking about bringing Medi-Cal revenue into your organization. Okay. All right. That's it for our presentation on the two new Medi-Cal benefits. So now I just have housekeeping issues, things to remind you about related to capacity building and technical assistance. So this is related to CalAIM rollout, but I do want to encourage you, if you have not yet looked at the free technical assistance marketplace that the Department of Healthcare Services has, they've opened that up since the very end of February. And I want to encourage you, if you'd like help in navigating the site, I'm happy to hop on a call with your team and go through the application together. A few of us have scheduled or are in the process of scheduling that. But this is something that I'd recommend you get a head start on now because there are more vendors that are signing up to provide technical assistance. And I want to make sure that all of you have the support you need as you're pursuing the housing related community supports. There is still, round 2 is still open to receive grant funding for PATH cited, which is the Capacity Infrastructure Transition, Expansion, and Development acronym. And that is grants for agencies pursuing community support. So if you have not yet applied for round 2, I'd encourage you again to click on that link. And that takes us to our reach. So my request for you in terms of reading for this week is to check out that CSH Advancing Health Equity through Peer Workforce report. I think it's really rich. Carmen, you had an interview in it and it shares a bit more of individuals' personal stories, but then a lot around how to support peers in the workplace and what you need as an organization to get started. In the Explore section, I have 2 links. So one is exploring the frequently asked questions. About half of you are mental health providers or drug Medi-Cal providers, so you already are that provider type. So I'd encourage you to check out that FAQ section if you are. And then again, the TA vendor marketplace, I can't say it enough, so I put that link in there as well. Next week, our training is on Medi-Cal Managed Care Plan compliance requirements and claims processes. So this is going to be a really important one for you as you're thinking about what do you need to have in place to get a contract, or if you have a contract, what are plans expecting you have in place to be compliant with their standard processes and procedures and provider expectations. We'll talk a little bit also about building a quality assurance and improvement program, as compliance really means you'll want to have things in place internally so that you're not worried about a plan coming and doing an audit before you've gone and done your own internal review and house cleaning. And then I have a link here for you to evaluate today's session. So we'd love to hear your feedback. Was it helpful? Do you want to hear more about these benefits? What would you want us to do differently? And then finally, one more plug to join your area collaborative planning and implementation group. So this is another part of PATH. There are lots of parts of this PATH rollout for CalAIM, and this one is really around joining with other organizations in your area. Many of them are healthcare providers, so building those relationships that we talked about for either of these benefits will be important. You can meet them at these collaborative planning and implementation group sessions, and you can find your local collaborative by clicking on that link. And our final piece of reach is have ready. And I'm just wanting to encourage you, if you haven't yet started to gather your agency's policies and procedures or your manual together, the next few trainings that we have, compliance, policies and procedures, and documentation are all going to impact your policies and how you do business, your workflow and your process. So if you have those in multiple folders, I'd encourage you to start gathering it into one place so that when we start highlighting things of, oh, you might want to update this policy or make this slight tweak to this process related to compliance, you know, and you can quickly open up what you already have in place so you can highlight what might need to be changed during your review process. Carmen, I also just want to take a moment to thank you for joining. You took time out of your workday to be with us. I really appreciate that. I know you were leading groups and
No
busy.
problem. No problem. No
We really
problem.
appreciate you, and I really appreciate your perspective. So thanks for sharing.
You're very welcome.
And I just want to say thank you to everyone for joining, sticking with us.
Bye, everyone.
Bye-bye.
Thanks for having me, Cheryl.
Thanks, Carmen. I'll see you soon.
Okay.